Welcome everybody. Hope you're doing great. We're gonna have a couple of minutes for you to set in, to people to come in, because we really want you to see the setting today. We're so proud and so happy to have a setting like this, to work, academy, industry, everybody working together, pointing in the same direction. And that direction is for you to have better tools and have a better way to learn phacoemulsification. That's the surgery we all love and we want to spread all over the world. So welcome. Something very important. This is webisode number 5. And this happens fast. You guys know us, right? This is fast. But we want interaction with you. We want you to be in the chat, asking questions. The panel is there to answer. I'm going to be there looking also for the questions, the answers, the discussions. We're going to have a poll too. But please interact with us because today is for you. Okay? So let's move fast, and I'm going to show you what the setting looks like. You're going to see a lot of cameras surrounding us because that's the key. The first thing is I'm going to have this screen to show what's going to happen. We're going to behave like a professional simulation center. We're going to have a preparation of the students, a briefing, simulation activity, debriefing, reflection, and evaluation of what's happening. In this side, we have a bionicle setting with 2 artificial eyes. And if you come close, one of the important things is we're going to do Capsulorhexis. And look at this. This is going to be a fixed model, and this is going to be a moving model. So the skills are going to be, a lot harder in the moving eye. So what we're going to do is we're going to have an incremental experience. It's going to be harder and harder, but that's good because it allowed us to, to teach better some skills. We have this device too in one of the microscopes, and the cool thing about it is that we can have colleagues from all over the world. This is a micro-rec adaptator to the microscope. And we have, for example, a colleague from Germany, right? Giving our students some advices, okay? We're gonna have in this part, we're gonna have a constellation because when we're learning Phaco, we also need to understand what a venturi pump looks like. Here is my setting. Here is where I'm gonna be, just with all the models, with the different lenses, with an anterior segment, with everything, and also doing a lot of drawings about vectors, about concepts I want to talk to the students. In this station, it's even better because we have ingenuity, and in ingenuity we have an immersive experience with the students. Okay, so we're going to be with 3D glasses, everybody seeing what's going on, and also again guys, cameras surrounding us. And of course, people who know me, I need to have something to draw, and talk about these concepts. So let's go to the slides and let's start the show, okay? So welcome everybody. For those who are coming in, we want your comments. We want to have a very interactive session today, okay, guys? This is for you. So let's go to the slides. Perfect. So let's put the camera in front of me to talk to everybody. Welcome. Oh, sorry, no, the girl needs, sure, the doctor. Okay, perfect. So I need that camera, please, so they see us from the front. Can we put the camera from the front, please? I'm gonna start with the slides, okay? So welcome everybody. Welcome to one other webisode of Stop at Nothing. It's a pleasure to be here, with students, actually with colleagues, all learning from each other, okay? For those who are not familiar with the webisodes or what the Stop at Nothing webisodes are, this is hybrid blended education. What's happening is we have you on with an online connection. We have an expert panel. You're going to see it, amazing panel today. We're going to have a lot of hands-on demonstration. This panel is going to be, always giving advice to the students and me. We're going to have an active engagement. We have many questions for you guys, and we want your comments. And then this content is going to be on demand. One of the important things today is we're going to be on Facebook. Okay, today it's not going to be on YouTube. It's going to be in Facebook. So then you can see it, on demand in another time. Very, very important, and I'm very obsessed about this. This is deep learning. We want to transfer critical thinking, problem solving. We don't want you to, with a cooking recipe of the, the parameters or how to do the Capsulorhexis. We want you to understand what's going on. The environment, you can see it for yourself, right? We have the best environment here, so you can learn as much as you can. And this is for you. This is learning focus. This is not about us and talking about what we know. It's about you. One of my favorite slides, especially today, we're going to have the princess of the industry, and we're going to learn a lot from them. And this is what we believe. We believe in Latin America. We have this new ophthalmology in where academy and the industry we're working together. This is why we have Shemaine Labetsky with us. She's been so supportive with us, giving us so much advice and so many good ideas. So Shemaine, thank you for being here with us.
Thank you so much, Ivo. I really appreciate it. I'll quote Steve Jobs, and I would say that great things are never done by one person. They're done by a team of people. And I really think that that's what we've done together, partnering. It really sums up what we've done over the last 5 weeks, partnering with Ophthalma University and everything that the team is doing, as well as the Alcon Experience Academy and the Alcon Experience Center there in Mexico. So we have another outstanding panel today, and I can't wait to hear from them and get the audience involved with questions. Let us know where you're from. Let us know any questions that you have. And it's back over to you. Let's learn. Thank you.
Oh, thank you. Thank you. Thank you for all your support. And yes, I want to go very, very fast with these slides because I want you to go fast to the show on this amazing panel. For me, it's an honor to have Ashley Brissette here, a good friend that we have been sharing, many meetings and many webinars from the US, from Cornell. They are doing amazing things in surgery and in teaching. Another good friend, Ricardo Nose from Brazil. Everybody knows Ricardo, and he's a great surgeon, a great speaker, and always want to transmit good concepts. And Cecilia Torres from Chile. Also, we know her from a long time, actually, a great surgeon, and she's going to be here with us with many, many interesting concepts. As you guys know, Ophthalma University and the community of Phaco mentors in all social media. So I will love, for selfies and people taking a selfie with some of the cool slides and put them on Instagram, Facebook, and all social media. And this is the last webisode that we said with Shemaine all the time. We're getting sad because we're coming to the end. But in the end, we're going to have an anterior vitrectomy webisode that's going to be unbelievable. Okay, guys. So next week we want everybody, and we have actually a really interesting surprise. Let's hope we can make it happen. But probably we're gonna have another speaker there that you probably know, and he's gonna be very helpful, very helpful for everybody who wants to learn more about anterior vitrectomy. But we're gonna have Angie de la Mota from República Dominicana, Jonathan Lake, a very good friend from Brazil, and Siva Sayed from Wills Eye Hospital, amazing surgeon, talking about very, very interesting concepts. The goal here is simple. The goal today is to give you tools to become the cataract surgeon you always wanted to be. And the methodology, as you know, interactive activities. And also, especially, we're going to want to understand the journey that's going to happen. And why we want to understand the journey? Because of this. Because surgery and surgical education are changing and changing a lot, and they're changing especially in 2020. So Ricardo, I will love to your thoughts about how do you think surgical education is changing in this 2020, and how we can learn better at this time.
Hey guys, thank you for the invitation, Ivo. It's a pleasure to be here with you guys. So I think this new era of learning that we're living is assisting us, the mentors, and also the students to improve our skills. And we need to know that we will always be students. So we will need always to be studying and learning every day. So the great difference is that a few years ago, we basically learned everything from books, and watching surgeries and learning from mentors as well. Now we use everything available on YouTube, Facebook, social media, WhatsApp groups, everything that can help us. A few years ago, I think 2 authors published how they learned to perform DMAC just using YouTube as a mentor. So I think this part of the it's very important, this learning part, and using of Ophthalmo University and other platforms to learn is also very important for all the students and all the mentors to keep being updated.
Thank you, Ricardo. Thank you. Yes, we agree a lot. There's a lot of changes, especially there. We can see, there's not only economic changes, but technology, like you can see today, is helping us big time to learn more fast and efficiently. There's a lot of concern about patient safety. We're going to talk about that. And Cecilia, if you see that graphic and you see all this changing in surgical education, what are your thoughts about it?
Thank you, Ivo, for the invitation. I'm honored to be here talking about the subjects today. There are many changes. Some of them are what it's been said now, but nowadays we have a big change. When I studied, it was competition. It was envy, what you saw between the surgeons. Now what we have is a community, and you see that every day in different forums, in the chats at WhatsApp. In these settings, we are all trying to be the best for our patients, but not to be the best in comparison with the next one next to me, the best for our patients. And that's a big change in the world, I think. Other changes are technology. When I studied, technology was not what we have today. It was difficult. We had real search when we were operating. Now you have Centurion, now you have Active Sentry, now you have technology which makes everything easier. Easier not only for the skilled surgeon, but easier for the resident. On the other hand, as you were saying, it is much more difficult to find a patient who trusts his or her eye to a resident. Residents now have to earn the trust of their patients to be able to operate on a human being. And that is not only in books. You have to make a relationship with your patient so as they trust their eyes to you.
Excellent, excellent. Thank you very much for your comments, Cecilia. I think they're very accurate. I love this image. This image is me with a fellow, anterior segment fellow. And if you really see what's going on in that operating room, there is a lot of, factors that are affecting the learning. I always joke that the operating room is not a nice place to learn, actually, because you care more about the patient safety or time or many other things that actually learning. And okay, so I think this is a very interesting picture. There is a high pressure environment with time constraints, and patient safety is imperative. This is the second time we're saying this, and we're going to say it all along the night, right? I think it's very important to understand this, to understand what classic learning or classic teaching is. And right now, with technology, we are seeing this exponential learning, a completely new learning curve for cataract surgery. So in this learning curve, there is many items that actually we were discussing a couple of months ago with Ashley, that's here with us, and Ike, and an amazing panel. Everything is about to have a purpose to learn, to be motivated, to have a good mentorship, deliberate practice, and a growth mindset. Ashley, it's an honor to have you here with us. What are your thoughts when you see this new way of learning?
Yeah, I think it's so important to consider the environment and how that impacts the way that we learn. because I really think a lot of it is about mindsets, getting into the right mindsets, that you're a confident surgeon, because confidence is really key. But it can't be a false sense of confidence. It really has to be coming from the fact that you know that you're well prepared and that you're skilled enough to have the honor to operate on somebody.
Thank you. Thank you. Thank you so much. Cecilia, you have any comments about this new way of learning? You like some of those items?
Yeah, I think it all starts in the operating room. You have to open your eyes. The first 10 or 20 surgeries I assist, I wasn't able to see the tear in the posterior capsule until the surgeon told me it's broken. It's a tear there, because we have to learn to see through different transparent planes. You have the cornea, the anterior capsule, the posterior capsule, and all happens there, which is visible and transparent at the same time. So the first step is to open your eyes and learn to see. Then you have to learn some skills which are not only each step, but you have to learn. My mentor used to tell me, you don't have to see it, you have to feel it. And it's not a Zen mode, it's rather a kinesthetic approach. You have to feel where you are. You have to feel the rhexis. You are doing it right because you feel the tension on your hand. And that's something you have to practice outside the operating room first. We used to practice rhexis in the wrapping plastic of the package of the IOLs. And you practice 1, 2, 10 times till you feel it. And then you go step by step till you get to the human eye. But it's your eyes, it's your kinesthetic abilities, and then every step done one and many times till you get to do it properly.
Thank you. Thank you very much. I love that about feeling it. We call that awareness, right? To be aware of everything, be aware of the anterior chamber, be aware of all the structures and how they behave. Really love that concept. So we are talking about, Ricardo was talking a lot about this, right? How we learned in the past and the actual paradigm when basically you have patients right in the beginning, right? So to become competent, you just do a little bit of wet lab, something like this, something like that, and then you go right away to patients. And there is a feeling of many people that it's like the only way they can learn is in a human eye. And today is a day to talk about how that is changing, how these new paradigms we can have. We can have such a big experience before we get to human beings and patients. And we have this concept to talk about surgical readiness. Ricardo, tell us a little bit more about how do you think we can learn fast, we can learn more efficient today, and how we can train without having a human being in the operating room.
Great question, Ivo. So this is very important. In my opinion, the great advances come with good mentors, a good operating room, and also the partnership with the pharma company. So I can see your devices from Alcon. They're very supportive, especially when we are residents. So this is very important for us. So when we're learning, we need to have the equipment, the correct equipment for the surgeries, good devices like IOL, viscoelastics, everything that can make this surgery more safe. Another thing that I think is very important for an effective surgeon in cataract surgery is start learning from the backward. So start from the last steps of the phaco surgery. So start hydrating the incisions and then aspirating viscoelastics. And then every time you're increasing every step, you can start and do the phaco from the beginning to the end. So we know phaco is a surgery that is step dependent. So if you make a mistake in the beginning, can make your surgery a big nightmare in the middle and to the end. So if you are safe doing all the steps from the backwards, you'll be a better surgeon for sure.
Great. We're going to have a couple of questions for the audience. You know, they're very important to understand what are your current situation. We want to understand if you are a cataract surgeon, if you want to become a cataract surgeon, and for you to understand that there is so many different ways now that you can train safely and efficiently and become a cataract surgeon. So please answer those questions. They're going to be very important. And since we're talking about, you know, this way to do it fast, we have this concept that we love, that is the wormhole. For those guys who like physics and time travel and stuff, this is like hacking time, right? Let's go to point A to point B in a very different way. Let's do a wormhole so we can, you know, make time more efficiently. And these are three concepts we were discussing a lot. Let's see what people are saying. But Ashley, please, I think these are three concepts that are very, very important. And you being, you know, in the north side of the world, and where everybody has curriculums, they have, you know, assessments, they have a way to do stuff with protocols. What do you think about how we can improve, you know, the cataract surgery training right now to have it to be more efficiently, to have more efficacy, to be more effective?
That's a really good question. So I think that one thing we have to consider is that sometimes people learn differently. And so what works for every student isn't going to work for everybody. So I think you have to have some personal insight into knowing what's exactly going to work for you. If you're somebody that needs to maybe go to a wet lab more often, if you're somebody that learns a lot from watching videos, if you're somebody that needs to be more hands-on on a simulator. So there's lots of different ways that you can gain experience. So what I would recommend is to try all of these and then really figure out what works for you so that you're developing a way that you can best learn. I think having options is really important. So having access to a simulator, to a wet lab that you can use, online videos, speaking to colleagues, filming yourself doing different surgery steps and watching it back is all really important.
Thank you. Very, very interesting. And for us, this is very important, especially in Latin America. We're seeing what people are answering. And we have a lot of cataract surgeons. This is interesting. And that's very good because we can always learn something. But, you know, we have other people in the process. When we ask about the barriers or what's going on, what's happening, there is a 60% of the people telling us that there is not enough centers to train. In another ones, there is not enough surgery or not enough quality of teaching. But I think right now with technology, we're going to see what these guys think. But with technology, that can change completely. As we saw, that learning curve can reshape completely. And with centers like this, we can learn more efficiently, more effectively, and with more efficacy. But also, today is a very important day because we want to talk about safety. And we have David Easter here with us. And it's very important to understand how I think there is a big paradigm shift. And right now we are having technology to learn in a much safer environment. And you know, this is going to be a better experience, not only for the students, but also for the teachers. And of course, in the end, for the patients. So we're going to stop sharing our screens. David, it's such an honor to have you here with us. We know where you're going to talk about a lot about technology and some changes in technology that will help us to become better teachers. So please welcome. It's an honor to have you.
Thank you very much, and thank you for inviting me. I'm going to try and share my screen here if I can. Let's see. Hopefully this works for me. There we go. Hopefully you can see my screen now.
Not yet.
No, not yet. Let's see if I have the slides. I'm gonna see if I have the slides.
Yeah, here, hold on. You see the screen 2 yet? I apologize. Let's see.
Let's see if we can have a camera here. And
Yeah, wait a
maybe I
minute.
can show them from here.
Do you see it now?
No, no.
Okay, wait a minute. Share contact. I know why. It doesn't like me. I'm gonna have to
Don't
quit.
worry, don't
Yeah,
worry, David. We have them right here.
yeah, Zoom does not like me tonight.
You're not a Cowboys fan, right?
No, I am not a Cowboys fan. I apologize. I am
No,
not a
that's
Cowboy.
good. Because of the other day, a very, very tough game. Let's see if it opens. I don't know when it's taking so long.
I'll tell you what, if you go on, I will restart my computer and I can fix this.
Let's see if Lisandro, if you can fix this screen.
No, the audiovisual team must show the screen. I'm not able to.
Comparte la pantalla esa.
Now it is.
There we go.
Perfect.
Okay, so go ahead, second slide, please. You can go to presentation mode very quickly.
No, but that's yours, I think. That's yours, David. No,
It's mine?
It's
Yes.
mine. It's mine, but yeah. Okay, here we go.
Okay, perfect. So just very quickly, so, Active Sensory is a new technology that we brought out last year. And, I've heard a lot of discussions already that, we want to create a safe space for you as surgeons to work inside of. And we want to give you the stability and consistency, because that is going to allow you to not only learn, but also really take care of the patients. And so there are really three important things that Active Sensory brings to you as surgeons. Number one is it actively mitigates surge. The second thing is that it sets patient eye level automatically. And third, it adjusts for average incision leakage. And it does it because we are moving the sensor from the system to the handpiece. And because the irrigation pressure sensor is in the handpiece, we're able to respond to surge events and maintain your IOP at all times. And so it's not just, the sensor, but it's having the active fluidics. It's also having the FMS, which is designed to be able to respond quickly, and then all the software, which is in the system itself. Next slide, please. So one of the things that I'll show you in terms of comparison is that if I look at Active Sensory versus Infinity, which used to be the gold standard in terms of surge, this shows you the curve or the response over time to surge. And it's essentially how much fluid is flowing outside or from the eye. The greater the surge, the greater the chamber instability would be. The longer the surge, the greater the fluid that leaves the eye, and again, greater instability. So we've been able with Active Sensory to not only reduce the peak of surge, but also decrease the time of surge. So both of those things combined really end up providing you a much more stable chamber during lens removal. Go ahead, next slide. So there's another thing that we've done, and there are a few things I'd like to point out. We also, over time, have developed a new set of tips, both the balance tip and the hybrid tip. Now, what's different about these tips is that the shaft has no constrictions in it. They're not flared. And because they're not flared, material flows smoothly through the tips. It doesn't stop and start as it would in a flared tip. And this, again, helps us manage when you're cutting lens material to have it move consistently through the eye. So one thing that I just wanted to point out in terms of parameters here is that you want to really, if you're using a Centurion system, you want to consider having an offset at the initiation of nozzle amplitude. The reason is when you're at very low ends, really nothing happens. No cutting really takes place. And we recommend a maximum of 60% amplitude. With the hybrid tip here, we recommend going up to 80%. And that's really, it's kind of an interesting physics phenomena. But the tip itself, having the polymer over molding, actually dampens the amount of motion inside the eye. And so you can actually use a little bit higher amplitude. Okay, next slide. And I'm going to go a little bit quickly here. So one of the things that we want to talk about is that if you're a chop surgeon, the 30-degree bevel is probably better because it will occlude a little bit easier for you. We want to make sure that you match the right sleeves and the right incision with these tips. So here's just a quick little chart to remind you what that could be, what that could or should be. Next slide. So the other thing that we found is that you can have a lot of variance in terms of IOP during the case if you choose. However, our experience has been that if you set IOP consistently and not vary it either with foot switch position or step to step, the patient's probably going to be more comfortable. The other thing that we're able to manage because we've reduced surge and we can manage constant IOP in the eye, being able to now operate at lower IOP probably provides greater patient comfort. Greater patient comfort, we hope, will impart less movement of the patient, less concern of the patient, and keep everybody relaxed within the OR. Next slide. So I promised to talk a little bit about parameters today, and I just want to point a few things out. Number one is if you're coming from other devices, please make sure on the Centurion that you use a little bit higher vacuum. The tubing is smaller. The tubing, the aspiration tubing is a little bit smaller. If in the past, let's say on Infinity, used 80, you need to use a little bit higher vacuum because there's resistance with that small tubing. And if you have resistance, the vacuum goes up quickly and the pump stops. If the pump stops, you'll hear the ding, 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 ding. It means you don't have flow. If you don't have flow, you don't have cooling. So make sure that you use high enough vacuum, okay, so the pump continues to move as you are sculpting at the beginning of a case, for example. Next slide, please. Also, you know, when you go to either quadrant or chop settings, I'll point out, essentially, if you're starting, I wouldn't go above 550, and I would never go recommend you go above 650. And the reason is when you start to go above 650, you start to pull air out of the tubing when you get up to 650. And what that does is that then if you have an occlusion break, those little air pockets in the tubing line collapse quickly. And when they collapse quickly, you end up with instability. So you really don't need to or want to go much above 650. And I wouldn't start there, certainly if you're learning. Start about 550 or 500 so you have good holding, and then your energy will be effective in terms of cutting the lens tissue. So anyway, I wanted to go very quickly here and in part just a few things about the technology and the design. And hopefully this helps you a little bit in terms of understanding what we bring to surgery. So thank you very much for inviting me tonight. Sorry I couldn't show my slides
No, don't worry,
by
David.
myself, but thank you.
It's an honor to have you. It's such an honor to have you. David is the Global Director of Marketing of Phaco from Alcon. And, you know, I think there is a lot of technology that it's helping us in this entire learning experience. You're talking about active fluidics, which allow us to have a more stability in the anterior chamber. Right now, we're talking about active centric that adds a little bit more of stability and control of everything that's happening there. Also, the balance tip, you know, there's all surgeons talking about the importance of the efficiency, right? The protection of the incision, but also the efficiency with very, very hard cataracts that we have in Latin America. And finally, the hybrid tip. I would love for you, David, also to tell us, in your opinion, which are the value proposition of these four technologies that you're presenting to people in training?
Well, so we'll start with active fluidics. Active fluidics provides constant IOP inside the eye. And so you don't have fluctuations in terms of pressure. Active Sentry, as we said, probably the biggest issue is that you reduce the surge events. But also, how many of you, I'd love the poll, how many of you set patient eye level on every single patient? They have different size heads, the bed comes in, it may not be in the same place. That has a big impact upon pressure inside the eye. We eliminate that by having the pressure sensor in the handpiece. It's now automated. So you get the pressure consistently case to case to case. The other big deal is that not all of your incisions are the same. I'm sorry, you're not perfect, I'm not perfect. Incisions leak, and they leak as you move your hand when you're doing surgery. So now that we can compensate for the leakage, you have constant state inside the eye. So all these things are designed to give you stability, consistency. When you have stability and consistency, it leads to safety. The other thing I would just want to talk about just for a second is hybrid tip. So the hybrid tip in cadaver eye studies showed a 3 to 4 times less chance of capsular rupture when you hit the capsule and hold on to it. Okay, 3 to 4 times. So when you're training somebody or working with residents, it's going to happen. They're going to hit tissue. They're going to hit the capsule. They're learning. I mean, it's not easy. So this helps to reduce that risk factor, build the confidence, build the ability to see where you are and work inside the eye with another margin of safety. And so, this is what we're trying to do, is bring you products that give you control, give you the ability to manage the patient and the patient state, and do it as safely as possible. So anyway, thank you for letting me review those points.
No, and we thank you so much because, the mentors who are training students, we suffer a lot. So everything, that it's for the safety of the patient, it's welcome for us. And so thank you. And I'm just waiting to see this technology working in every patient. We have a couple of other, we're going to the big show now. Thank you for being here with us, David. And we're asking people about the quality of teaching now. We're talking about this new learning curve. We're talking about this new technology helping us to be more efficient, to be more safe. So take a few seconds to tell us, what do you think, about the quality of teaching, the number of surgeries you're doing? What do you think about that? And which are the most important factors to learn cataract surgery? There's many different issues. Again, a number of procedures, quality of mentors. Which do you think are the most important ones? And right now, let's go back to the moving camera here, and we're gonna start showing what's gonna happen now, okay? So we're gonna change with the mobile camera. Let's see if you can see me there, guys. Let's see very quick about the results of the invitation. There is, do you think the number of cataract surgery procedures, it's enough? There's a 70% of colleagues saying that there's not enough cataract surgeries. That's very, very interesting. And about the other question, it was kind of a tricky question because, you know, all items are important. 75% of colleagues said that everything is important. It's not only about the number of procedures. It was, oh, how many cataracts did you do in residency, right? But it's there's a lot of more items that are important there in that equation. So let's hope you can see me there. You can see me here. So we're gonna go to the first station. So Ricardo, Ashley, and Cecilia, please. I will love your comments. We're gonna start an incremental experience. Okay, so this is gonna be like this. We're gonna have a still eye, okay, with no incision, and we're gonna do a capsulorhexis. Then that eye is gonna be complete. We don't have a cornea now. Okay, we're gonna have a cornea and we're gonna do a capsulorhexis. Then we're gonna have a moving eye. Okay, and after the moving eye, we're gonna start doing some phaco. And actually, this is very important too because there is a difference between doing the right eye and the left eye. So let's come here with the, you know, with the camera. Let's see if we can see this, you know, this signal with the hands of Marcela, who's our student. So please, let's start doing that capsulorhexis. So as you can see there, she already has the incision. We have two ways to do it, right? In this case, we don't have a cornea because what we want is to talk about all the components that are involved in a capsulorhexis. And this starts in the hand position, okay? The hand position is very important. Then we're gonna talk about what we call the incision awareness. And especially this model is important for the incision awareness. And then we're gonna talk about what vectors are happening in the capsule. So please, Ashley, I will love your comments about this. You know, when you get to train your residents about, you know, hand position, floating, and incision awareness, what are your comments?
The big thing with making the capsulorhexis, I agree, is being aware of where your instrument is in the incision, because you actually want to be pivoting within the incision and not at the edge of the incision, trying to gape the incision open up or down. So you actually want to use the incision itself and pivot the instrument within it to get to where you need to go. And that's important for a few reasons. One, so that you're not creating any disruption for the wound. And two, so that you're not burping viscoelastic out of the eye. Because again, you really want that anterior chamber very stable. And so you want to have a nice kind of pressure there so that as you're creating your capsulorhexis, you're not causing any decrease in pressure, which could lead to tears. So with the hand position, be really, really cautious to just pivot within the incision.
Great. You're talking a lot about pivoting. Let's see if with this camera you can, you know, she's still doing the movement, but come with me because we're always, you know, about what's happening inside the eye, right? We have so many videos around. We have so many different colleagues doing capsulorhexis in a different way. But right now, we're going to talk about this, okay? What's happening in this environment. And we're going to talk about exactly that. Hand position, incision, awareness of floating and pivoting. Ashley, where you were talking a lot about pivoting. Cecilia, what are your comments when you have a resident and you're seeing that he's moving the eye a lot, he doesn't have control, this viscoelastic is coming out? What are your thoughts?
Now you hear me. The most important part is what Ashley said. You don't have to go back with your forceps. If you rest down back, the incision is going to open and you're going to lose all the viscoelastic out of the eye. You have to pivot there. And other important thing is that you have to think that if you go in the direction you want to go when you are opening the rhexis, but sometimes you want to close it. It's going too open, too wide. You have to close it. You have to come tear that one hand just in front of where you are, 180 degrees from where you are. That's what's going to close your rhexis, and you have to practice that many times. You open it and you close it. You open, you close it, because when you are losing the tightness there, it opens, and that's when you have the worst complication at this step. So you have to practice that movement.
Excellent, excellent. So as you can see, guys, there, she did an amazing capsulorhexis. She's very well trained, and we started, from the hand position. Let's come back here. These are three things I really like. Let's see if that camera is seeing me. The hand position is very important because it's the stabilization point or the tension of the eye is. And then we are allowed to float or to pivot, okay, through that incision. That was Ashley was saying, right? The eye doesn't need to know that we're doing something through that incision. And that's why next case is going to be with a moving eye. It's going to be a lot harder. Okay, so we're talking about floating. We're talking about pivoting. I'm going to do a couple of images of how I teach that, and let's go to the other station. We're gonna, yes,
Ivo, I want to say something else. You have to choose an appropriate forceps. As many years ago, surgery was different. We many times go to operating rooms which don't have the appropriate equipment. So you have long forceps in micro incisions don't work, because you have to take many times once again your capsulorhexis, your capsule. You need a smaller, shorter forceps, especially in the left eyes. You said right eyes are not the same as our left. Yes, when you have to operate your left eye and you're right-handed, if your forceps is long, you have the nose there. You don't have space because you have the nose of the patient there. So you have to look for appropriate forceps. And I suggest the tooth utratas, because you don't have to do the cystotome. With the tooth utratas, you do the first tear and then you take it and you go on. That's nice.
Okay, we are adding something, a very important tool. We're using technology. This is when we have some colleagues that they want to put a multifocal and want to do a perfect capsulorhexis, but in this case we are using augmented reality, so the resident can understand and especially have a guide about the size and the location and the shape of the capsulorhexis. I think this is very important. Ashley, we see you all the time with amazing technology there for Cornell doing surgery. Do you think this is something good to teach?
Yeah, I love this. We have this available at Cornell where I teach, and it's really important because as you're learning cataract surgery, visually it can be very deceiving by how dilated the pupil is, by how big you should make your capsulorhexis. And we know the capsulorhexis should be around 5 millimeters or so. And if somebody's really widely dilated, you might actually make it bigger than you anticipate. And if they're not as well dilated, you might make your rhexis smaller than you anticipate. So using this overlay can be extremely beneficial. If you don't have access to this technology, because not everybody does, you can see on these forceps here, there's actually a marker on them. And so about halfway down the forcep would be about 2.5, and then a full length would be about 5 millimeters. So you can also kind of guesstimate with the forcep itself about 5 millimeters for an appropriate size capsulorhexis.
Very good one. A very good. That's a very good topic. So I hope you can see this camera. We're moving big time here. I hope everybody can follow me. But here I want to talk about two things, and it's very important to draw them. Okay. The first thing is about what we were talking. Imagine that this is the incision itself. Okay. It's not like this, but when you have an instrument, okay, when you have the forceps, one of the most important things to learn, and some, it's not easy to learn, is that forceps has a limit, okay? And the limit is the incision. If that forceps goes out, what's gonna happen? The eye is gonna move, okay? The eye moves if the forceps pushes the incision. So the key here is to be able to go from one place to the other one, okay? You can move in this size, but when you go out, the problem is the eye is going to move. You don't have a good reflex, and that's going to be a problem. So this is the pivoting in another dimension. The other thing is as you can see here, let's grab another color, is the roof. Okay, you have a limit up and a limit down. What happens if you go down? That's a big problem, because viscoelastic will come out and the rhexis is going to go away. So remember, guys, you need to float through the incision. If you go up, you are going to have stria in the cornea. You're not going to see well, and that's going to be a problem. And this concept that I love, it's extremely important just in this area. Okay, this area is the subincisional area, and we're going to see what the students are going to we're going to do now, because now they're going to have a moving eye. Okay, and that's going to be a problem for them. And in this area, that is the subincisional area, the most common mistake here is that they don't do the pivoting correctly, and the capsulorhexis can go out. Okay, big problem. So the movement we're going to see them do is to have the forceps right here. We grab the capsulorhexis here, and then we're going to pivot to bring the forceps this way, and the movement of the forceps is going to be to the right, entering the eye. Okay, remember that, guys. Look at this. Here it's going to be like this and up, and we're going to see the right there with Marcela in a moving eye. So Marcela, you're going to have a hard one now. Okay, so look at this, guys. I did first a right eye. There was a model of incision awareness. Right now she has a moving eye, and it's a left eye. So look his hand position. She's going to struggle a lot, because now, the capsulorhexis is in the left eye, and with a moving eye, that's going to respond to her movements. Cecilia, what are your thoughts about these concepts I'm talking about? Cecilia, are you there?
Yeah, I'm here. I was mute. So the first is you start with peribulbar anesthesia, holding the eye with the forceps. But I think that when you go to topical anesthesia, you have to change your way and not use forceps anymore. I know that there are many opinions in this way, but I use a cotton swab just to hold the eye. That's gentle, very gentle, because when you take the eyes and fixate it with the forceps, patient felt it, and the patient starts to move. You start to talk to the patient, don't move, And that's not the way. That's when you start, things get worse. You have to try not to fight against the eye, fight against the patient, but rather making things smoother. One idea is to use a cotton swab to fixate the eye.
Perfect, perfect. Ashley, your thoughts on these concepts?
Yeah, I think this is extremely important that, whenever we think of doing something in real life is when it becomes so much more challenging than even practicing just in a wet lab. I'll often do what she was simulating here, where I hold the other part of the eye with a forceps just to really stabilize the eye. Because again, it's so important for this part to have it as still as possible and as stable as possible. So I often do my capsulorhexis with 2 hands on my cystotome and on the utratas. But then if the patient's moving or I'm afraid that they're going to move, I'll actually just do it one-handed and I'll hold with my second hand with a forceps on the conjunctiva to stabilize the eye.
Perfect. And as you can see here, those concepts I was talking about started to show up, right? We had an eye that was completely stable. So now, every time she moves through the incision, and remember, guys, the limits, if she doesn't respect the limits and she doesn't pivot, the eye is going to move. And this eye is going to move a lot. But that's a good thing. Why? Because I want all the residents to train how that eye is going to behave in real life. So I think this is going to be a great experience. Again, for everybody. Well, she got lucky because she's a left-handed, so the left eye wasn't that the bigger of a problem. But for somebody who's right-handed and did the right eye, and now comes to a left eye moving again, that's a very incremental, an incremental skill to learn. But that's the good thing. That's what we're talking about. You don't need to go to the yes, sure.
Here we have some input from Pablo Robles. He says he uses second instrument. Our chat. Pablo is saying he uses a second instrument in the paracentesis. That's a very good idea. When you have a cotton swab, you have a dry cotton swab and you fixate the eye, and that's useful in most of the cases. But when patients start to move, you can use your forceps, but you can use what he says. You can take your Drysdale or any other instrument in the paracentesis, and that is going to work very well to fixate the eye without causing pain for the patient, which is going to make him or her move. That's a very good input from Pablo Robles.
Yes, very good one, and it will allow you to stabilize it. But then again, if you do the movements correctly, you will not need to stabilize it because the eye will not know that you're in that incision. She's doing an amazing job and an amazing capsulorhexis. Ricardo, are you there with us to have some inputs about this?
So yeah, she did very well, this capsulorhexis, fantastic. I try to teach my students to always use both hands. Why? Because the surgery, the way I do, I use always 2 instruments to move the pieces, in, the lens pieces, the cataract pieces inside the eye. So I try to tell them to stabilize the eye with a Sinski hook or a chopper. You can hold in this paracentesis and use the main incision to do the capsulorhexis like this. So this is my the way I usually do, especially because 99% of my cataract surgeries are topical. So this is my idea. Okay.
Excellent. Let's go to the very good one. Marcela, great, great job. Let's go to the other capsulorhexis here, but I want another camera to look for these 2 concepts, because right now we talked about the hand position, we're talking about the incision awareness, And let's see if you can see me here, to see these amazing concepts that we have at the screen.
We are not seeing.
There you go.
Yes.
There's two ways to make a vector in the Capsulorhexis. We have Dr. Laura Modamio from Spain. She's sleeping now, but she was kind enough to do these two drawings. And this is very important when you're learning. You have two ways to control the Capsulorhexis. One way is to do sharing, and another one is to do ripping. They're not in contradiction one to each other. Maybe they can be present in the same movement. But what I want to tell you, and that it's very important, is about sharing, is that the vectors, they go in the same direction and you control more the cut. What you do is you just make a flap from the Capsulorhexis and you just take it in the direction of the traction and the tear are the same. When you do ripping, and this is very important, but because if you are going to do a Capsulorhexis, you need to have a way to rescue that Capsulorhexis if it's going to the periphery. So the ripping maneuver is going to help you, to change the direction of the tear to the center. Okay, there's different concepts. We could talk for hours because I have seen so many surgeons do one and another one, but these are two important concepts to have. Let's go to the final example of Capsulorhexis, and then we're going to go to Phacoemulsification. So let's see if we can see that here, but because Pablo is doing an amazing job here too with the ingenuity. Very good. Let's see if you can see the flap there. I'm going to put the, any comments about this, Ashley?
Specifically for his technique or for this ripping motion?
Yeah, what do you think? What you do sharing, you do ripping when people are learning, what do you recommend?
The big thing I think when you're learning and you're following with the Rhexis is that you want to make sure that you have somewhere to re-grab. So I often kind of tell the people that I'm teaching that you almost want to leave it like a sail, where a sail is standing up so that you can go back and re-grab that sail that's standing up. The last thing you want to do is have the flap or the edge of the Capsulorhexis sitting flat and then trying to grab it and lift it up. So if anything, you want to make sure that you're standing it up before you reach around to re-grab, and that'll just allow you to continue that motion where you're kind of continually kind of tearing in that circular motion to get it to come back towards you rather than trying to reach for it and find that edge.
Perfect. See? Excellent, excellent. Cecilia, any thoughts about this?
I think it's what I was trying to say before. You have to learn both movements to use them when you need it. When you need to a Rhexis, you have to rescue a Rhexis. You have to have that movement trained so many times that when you need it, you have to do it with decision. You can't doubt any second, because it's very that happens very fast, especially when you have those white cataracts that you grasp them, you just tear at the center and they go. So you have to rescue in just a moment. You have to practice this many times so that when you really need to rescue Rhexis, you can do it right away.
Excellent, excellent. So Pablo is doing the Capsulorhexis. Look at that beauty.
And one point is that you have to learn to do it clockwise and counterclockwise, because sometimes you start a Rhexis, you are in the middle of it, and you have problems, and you have to take the other end and start again in the other way. So as a resident, you have to train yourself in both directions.
That's a very good advice. I love it, Cecilia. And if you really think about it, when you're comfortable with the human eye, to do clockwise, you will not go unclockwise. I have seen that so many times. But if you have a simulation environment, then you can try, right? This is one of the powers of simulation. I think this is something we need to talk about. We need to talk about fidelity, that this is how these eyes behave, and if you can learn from them, you can learn so much from these eyes that it's very, very important. Uh, you can also you're also in an environment that you can communicate, and we can be with each other and talk and do that task many, many, many times. Just for matters of time, we're going to do a couple of with those eyes, we're going to do a couple of cases with the phacoemulsification. So please, you're going to start, Marcela. Start. Let's see if everything worked well. And actually, I put her, a constellation machine, because it has a completely different pump, completely different behavior, but everybody needs to learn in different machines. So we're gonna start doing some fake emulsification. I think we learned a lot from Capsulorhexis. We understood that you can learn so much in models like this, but in fake emulsification, this is where the magic really happens. Why? Because we're going to have a machine, okay? We're going to have to listen to the machine. This is going to be so important, to listen to the machine. It's going to be very, very, there's theories about how we learn, and when you can mix what you're seeing with what you're hearing, with how the anterior chamber is behaving, is very, very good to learn. In these models, this lens behaves very similar to the human eye, and this is very important at the time to learn. Okay, so yes, the eye is moving a lot. Let's see which camera we are in. Perfect. We're with you, Marcela, and she's struggling a little bit because the eye is moving a lot. So there you go. Now we have the phacoemulsification there. Let's see, because we have a failure in the machine. And if the machine doesn't work, let's see for the technical people to fix it, and we go to the second eye. Let's go to the other eye while the constellation is getting fixed. So it's your turn, Pablo. So we're going to be here with the Centurion. Okay. There you go. Something very important is how the tip is going to enter the eye. Perfect. Remember el segundo instrumento para la incisión. ¿Hiciste paracentesis? Sí. Perfecto. Very good. So let's do some fake emulsification. Ricardo, what are your thoughts about this? This is one of the most difficult steps to learn in fake emulsification, don't you think?
Yeah, definitely. I think the most difficult is the Capsulorhexis, but phacoemulsification involves different movements. So that's the beauty of this surgery is during the procedure you have to perform different hand movements and finger movements to perform a very nice surgery. So what is important to do sometimes when the tip gets a little bit tight like this, like we can see, it's good to have the other device in your hand, like a Sinski or a Chopper, to hold the secondary incision to assist the surgeon. Now he's sculpting, I think, for the fracture. So my advice here is to hold, yes, like this. You can hold the incision as well and sculpt, and then do the fracture. Okay.
Perfect.
So let's see how Pablo performed.
There is so many things to learn here, right? Especially we can see, what David was saying in the beginning about how you can lose so much fluid from the main incision while you're moving. You need to move very, very still in that incision, and you need to float. You need to float to the incision in this time too, to protect it and not to burn it. But he's doing a very good job, but there is so many things, because this is the key here, guys. There is so many things here happening. His foot pedal, 2 hands, you know, 2 feet working, watching in 3D, and making decisions. So this is Phaco surgery. And he's doing a good job, but he's integrating. Look at that. He's listening to the machine. The machine is talking to him. He's saying, you know, they have some occlusion. You can hear the pump rising, the vacuum. So imagine if you are able to do 50, 60, 70 cases, and you understand how the machine works. You know how the pedal is going to behave. Look, he has some fragments there, but he's in a scouting. So what's happening, Pablo? No. Now we need to change the quadrants because you need more vacuum. And we're going to start doing something we love is the 2-3-2 we talked about, right? We're going to do some vacuum. You're going to have the fragment and you're going to do position 3. Slowly 3, 3. The sleeve position, it's even important. As you can see there, the sleeve is too close to the actual tip. So do position 3. You're not doing position 3. I'm not hearing the 3. There you go. I want you to occlude, and it's behaving a very hard cataract. And this is good because he's facing a very hard case since the beginning. Look at that. Okay. But I want you to occlude the tip. Okay. And then when you occlude the tip, then you're going to deliver position 3. Ashley, tell me your thoughts about when you're doing emulsification of the nucleus.
Yeah, so for my big tip, I think for sculpt would be that you don't have to go very long, but you do have to go deep. So the length of your sculpt doesn't matter as much as the depth. So you want to make sure that you're deep enough, and then you need to get your instruments into the base, right into the base of where you've sculpted, and push those apart. You can do a cross motion, or you can pull them apart, but it has to be right in the depth and how far down you've gone to be able to get that good first crack. And you need a good crack to have the pieces really well separated so that they can come up out of the bag, because you want to be phacoing at about the iris plane. So we talk about cornea plane, iris plane, and in the bag. You're going to grab the piece in the bag and you're going to pull it up to the iris plane, and then that's where you're going to phaco. And that's a very safe place to be inside the eye, especially with the stability with the Centurion and the active fluidics. It will keep things very stable and it will keep the bag back. So when you're phacoing at iris plane, you have very little risk of going anywhere near the bag. So those would be my biggest tips.
Amazing ones. Cecilia, some tips for this step? Again,
first, Pablo is operating, yeah? Pablo, first I will go for the loose fragments. Those loose fragments that are chatting over there are going to... They are going to disturb you every time. So once you have work on them, then go deeper. But if you're trying to go, you see that the loose fragment is over your vision. Yeah, that's it.
Very good. Very good advice, Cecilia. And you need to remember that this is behaving like a very hard cataract.
Yeah, I know.
But he's doing a great job. And you're talking about...
We've been there so many times. You have those little pieces going around everywhere, and they damage the cornea. Those loose fragments are responsible for most of the corneal edema you see the next day. So you don't have to let them go around freely.
Very good one.
That's very good job.
Pablo did a very, very good job. Congratulations. Let's come to this concept. I think Cecilia said it very, very good. Let's see if you can see to this camera. Let's see. I'm making Lisandro work a lot today on the safety zone, guys. So Cecilia was saying, go to the loose fragments, take it to the center. There's something called the safety zone. And we can practice this in a 3D. It's a 3D area, right? So remember, guys, here's the endothelium. He will remember you forever. You do too much ultrasound, he will remember you. Here's the posterior capsule. You know, this is a very important thing. If you break that capsule, then you need to watch Webisode 6. What's going to happen in an anterior vitrectomy? You don't want to do that. Okay, guys? And the safety zone is a three-dimensional zone in which Pablo, will go to the fragment in position 2, will grab it, do a little three and grab it to the safety zone, and always do ultrasound there. Okay, this is very important. Just a quick reminder, guys, there is a lot of people asking and writing about other countries. If they take a picture to this QR, we can give you tools for our curriculum. What are we doing? The methodology for training, because there's people, for example, from Honduras, Nicaragua, and other countries asking. Everybody who wants to learn a little bit more about this, they're coming. Just the last thing, and I am very obsessed with this. I wanted to say it anyways. We are here in the machine, okay? You need to understand how your software and your hardware works when you're learning something, anything. And in this case, there is sensory memory, okay, that will go to something called the working memory that will encode everything and storage it long term. This is important for you. What happens is that when we encode, there is a limited capacity. We have a limited capacity to put information in long-term memory. And what we're doing here, it's called the dual encoded theory. We're hearing, and we're watching what's happening. So we augment that limited capacity, and we have more long-term memory. Okay, this is very important to learn. Let's go to the final case.
Ivo,
Yes, yes.
I want to share some thoughts with you. I read some minutes ago people complaining about they don't have been sponsored to have a wet lab or this kind of wet lab. I will tell all my friends from Latin America and from other places, we don't need so much to do this. We need our will and our time and our dedication. When I was a resident, we didn't have bionic eyes. We didn't have Phaco machines only for learning. We had to stay after the operating room closed. We took pig's eyes. We use alcohol with an injection. You go to the crystal to the lens, and that you make that way you make the cataract. You inject alcohol in the pig's eyes, fixate it to a cardboard or anything to keep it still, and you operate on a pig eye in your operating room in your hospital after the normal after it closed. So don't be disappointed because of money, because we are in Latin America, because no one sponsors, because the teachers. If you are residents, you take these videos, put them in your phones, and do it yourselves.
Very good. When we talked in that first learning curve, we were talking about motivation, and I will add another important word when you are becoming a cataract surgeon, and that's commitment, right? You need to understand what is to be a cataract surgeon. Being a cataract surgeon is not always fun. No, yes, no. So I'm gonna make you struggle big time with the entire segment because it's moving. Sorry. So don't worry. Let's come to the final comments. We have 1 hour and 15 minutes. We're doing so much. We're doing amazing things. We talked about Capsulorhexis. We talked about Phacoemulsification. There is so much to learn. Come with us, Marcela. You did a great job. I want to congratulate these two, brave colleagues that they're live doing a lot of surgery. We had a great time today. We learned a lot, but this was like, what, 5%, 10% of what we need to learn. The idea today was to give you an environment and an amazing panel to learn from each other. But I think we can learn in an environment like this. I would like some final remarks, some final comments from Ashley, from Ricardo, from Cecilia, from David, is he's still there, from Charmaine. So Ricardo, you can start from some last comments of what happened today.
So first, I would like to congratulate Ophthalmo University, Ivo, Andres, and all the guys are doing an excellent job. I think nowadays we have lots of ways to learn how to do better Phaco, especially the students and residents and fellows. It's very important to have the support of the industry, especially in the hospitals and centers, surgical centers that have residents and students. I think what we're experiencing now, it's very important. So what you guys are doing, combining techniques, technology, and the industry is very important for teaching. It's also very important to have always a good mentor besides you, student, when you are doing your residency, when you're learning. It's always good to watch and learn from more experienced surgeons. Now we have YouTube and all these channels easy to use. It's easy for you to learn different techniques. You can try to do different techniques of phaco, fracture, IOLs. You can learn. Now we have lots of different IOLs and technologies. So I think the way I learned Phaco is dying, and this is a new way to learn, especially nowadays with this pandemic. I think this will increase this online learning, and I would like again to congratulate all my friends, panelists, and my friends from Ophthalmo University. Because this is very important for the future of ophthalmology and especially phaco learning. Okay, so congrats again.
Thank you so much, Ricardo. Amazing words as always. Thank you so much. I want to ask a question to Ashley because I'm watching the responses, and 94% of our audience is talking about curriculum, benchmarking, milestones, good feedback, good mentors. And I do believe that in Canada, that in the United States, that there is a lot of this happening in cataract training. What do you think about this, Ashley? What can we learn from you?
Yeah, I think that's a really important part to learning. I think if I can give any piece of advice, it would be one, to film yourself doing surgery and watch it back. That's the most important way to get feedback from your colleagues, from your attending physicians, is to actually watch the videos back and ask for specific tips. So I think that is part of the curriculum. The second thing I would say is to make sure that you're being safe and show the attending surgeon that you're operating with that you're safe and you're in control. There's nothing worse than getting excited and wanting to show that you can do the entire case and that you can get through all of the phaco, even if it's challenging. But it's more important to show that you're safe. You can maybe step back if you're not completely ready and then come back into it when it's a more safe environment. And in the end, you will get more cases that way when you prove that you're a safe and controlled surgeon.
Wow, thank you so much. Yes,
I think that's great.
I was going to ask you that exactly, the word safety again, right, David?
Yeah, so, there's so many things that, I listened to and learned tonight as well. Observe. My comment is, observe and learn from everybody that you touch and everything that you watch. Phaco is a multi-sensory experience. And you mentioned that tonight. Learn the machine sounds, learn what they mean, understand and be a student, not just of the surgery itself and the steps, but become a little bit of a student of how the machine operates and fluidics and energy delivery and how that relates to what you do. And I think you'll become a better surgeon. And the only other comment that I will make is, we have been committed to try and help educate as an organization for years. So please, we try and train our people to help you. So please don't hesitate to reach out to anybody on our team worldwide to come to you, to spend time with you, and try and make you a better person for the patient, because we're in this game together. So thank you very much for the time tonight.
Oh, thank you, David. It was an honor to have you. Cecilia, some last comments before we finish?
I will make a personal comment. I met you in Dallas in 2018 in ARS in Fort Worth, and you told me you've been in Chile, just in the same hospital del Salvador, some years after I did my residency. And you told me Phaco was not an easy journey for you, not in Uruguay where you were born. That's how you got to Chile those years. Then you went to Mexico. Then you went to Barcelona. You told me that in a bus in 5 minutes. and I don't know if the audience knows this. Phaco has not been an easy job for you, but this passion that you've been following all these years is what we are experiencing now. Because of your passion, you've made this, you are teaching Phaco, and you followed your dream. And that's what you and every one of us is telling these residents. Don't get disappointed. To be a good surgeon, you have to be confident enough to trust yourself that you can do it. And you can make a person who sometimes is a blind person, and you make them see. This is not an everyday case today, but you do that. We do that. You have to be confident enough, but you have to be humble enough to look for your mistakes and to improve your skills, to get better, to do it better, and to help others do it better. So I thank you, Ivo, for your passion, because all of us are enjoying the product of your work.
Oh, thank you so much. You're gonna make me cry. And yes, this has been a long journey, not an easy journey, but then again, passion and hard work and commitment, but can make me, be here with you on all this amazing panel again and be connected with all colleagues around the world. I really want to thank Pablo as well for being here. Marcela, thank you so much. You were very brave to be here with us. Also, Luz Marina is there, and Andre translating. We are in Portuguese, we are in Spanish, we are in English. Charmaine, some last words. We're getting kind of sad, right? Because it's coming to an end.
Yes. Ivo and I said we're going to cry after next week, because we really enjoyed these last 5 weeks. One more week next week. We're working on some new things, hopefully for next year for all of you. And you just have an amazing team there at Ophthalmo University. I want to thank everyone also at the Alcon Experience Center there in Mexico, really supporting us behind the scenes. Really appreciate that. The residents, the panel, an amazing panel. Thank you so much for your time and dedication. And we really look forward to everyone coming last week and celebrating with us. Thank you so much.
Oh, thank you. And thank everybody. Thank everybody for being here with us, this night. I know that time is limited again now, but you're giving us your time. You are the most important thing tonight. So thank you. And I hope for those, as Cecilia was saying, for those who are motivated and want to become a cataract surgeon, you can do it now. Okay. So we're going to try to help you do that. So thanks to all the panel, Ashley, Ricardo, Cecilia. Thank you so much for being here with us, and good night to everybody.
Bye.
Good night, everyone. Thank you, Dave.